Good afternoon, dear colleagues. My name is David Grimaldi from Brussels, and it's my pleasure to share with you some data about RSV infection in the ICU. I have no conflict of interest regarding this presentation. As you may know, the respiratory syncytial virus is a paramyxovirus that causes hivernal bronchiolitis epidemic. The graph on the left part shows you the number of cases in Belgium last year. And you can see that as in all Western Europe countries, the peak is typically in December. On the right part, the graph shows the age repartition in the last 10 years. And you can see in green that obviously RSV infection concern mostly children before 2 years old. So you may think that you are here in a pediatric symposium. However, you can see in this nationwide data that the proportion of adult patients in blue, especially those over 65 years old, is increasing along these years. And as the number of cases in RSV epidemic is huge, even if adult patients represent only 10% of cases, at the end, this is a significant number of adult cases. And indeed, since 15 years, RSV infection of adults have been clearly recognized. In this pivotal study published in 2005, Falsi and colleagues included outpatients and hospitalized elderly patients that were systematically tested for influenza and RSV when they had respiratory symptoms. And you can see in the table that they observed indeed a similar incidence of both viruses. Of note, the rate of admission in the ICU of those patients was around 15%, and it was very similar between influenza patients and RSV patients. And clearly, looking at this literature, we can observe that given the generalization of multiplex PCR that allow to detect several viruses in the same run, the isolation of RSV in ICU patients is increasing in the recent years. And in the few reports that were interested in that purpose, they found that 5 to 10% of adults admitted for respiratory infection in the ICU had a positive RSV sample. For instance, you can see on the right, in a single center study in Korea, published in the Blue Journal in 2012, that the number of RSV admission compared very well to the number of patients admitted with influenza infection. Of course, this observation does not answer to the question of pathogenicity of RSV and the meaning of finding this virus in airway of our patients. In a large monocentric study in South California, published last year in Clinical Infectious Disease, the author observed, based on medical records, that elderly patients hospitalized for respiratory infection, when they had RSV infection, had a greater mortality than influenza. Of course, this observation is limited by bias, such as imbalance in comorbidities between the two groups of patients, the unknown ICU policy admission, and so on. So clearly, this does not demonstrate that RSV is the biggest killer than flu, but it provokes some questions. And with this data, we have new questions about RSV in adult patients in the ICU. What are the characteristics of the respiratory failure when the patient is infected with RSV? What is the prognosis once in the ICU? How does it compare to influenza? And to answer these questions, we conducted the captive study in France and Belgium, ICUs. Our aims were to describe the patient's characteristics and the respiratory symptoms of those that were infected with RSV, to describe their outcome, and to compare to influenza patients admitted in the same ICUs in the same years. Briefly, our method was a retrospective multi-center study in 18 ICUs. The study included patients over a 6 years period, and we included patients with positive RSV sample and matched them with patients with positive influenza sample. The matching criteria was simply that the patients was in the same center in the same year, and to have a random effect, the matched patients was the closest patients admitted in the same ICU. Our primary endpoint was hospital mortality. Secondary endpoints focused on ICU outcome. Let's go to the results. We include 320 RSV patients admitted in ICUs that were matched with 320 influenza patients. You can see in this table that demographic characteristics were similar. We observed more smoker and former smoker in the RSV group. Among comorbidities, chronic respiratory disease was clearly more frequent in RSV patients, involving 60% of the patients. And the most, of course, disease was COPD. Immunodeficiency was also more frequent, and you can see that it involved roughly 1/3 of the patients. For the other comorbidities, I do not show the data, but the proportion was very similar between both groups. At diagnosis, almost all patients were in the ICU for medical admission, for sure, 99%. The main ICU admission reasons were de novo acute respiratory failure or acute and chronic respiratory failure. And you can see that this last cause was more frequent in RSV patients, in line with their comorbidities, their smoking status, and so on. SAPS-2 score were nearly identical, maybe a little bit higher in RSV patients, but SOFA score was higher in influenza patients, and you can see on the last slide of this table. Regarding the symptoms, most of the patients had respiratory symptoms. There was slight difference regarding wheezing between RSV patients and influenza, but conversely, extra respiratory symptoms were also not frequent, but they were clearly more frequent in influenza patients, concerning 17% of patients compared to 8% only in RSV patients. Finally, influenza patients were more febrile, as you can see on the graph on the right. At physical exam, patients with RSV had more frequently bronchospasm, less frequently crackles, but you can see that both conditions can have both abnormalities, and the chest X-ray was quite similar across the two groups, maybe more diffuse infiltrate, bilateral diffuse infiltrate in the influenza group, but this is 34% compared to 26%. Co-infection was frequent, found in 1/3 of patients, but similar between RSV in red in this slide and in the influenza patients in blue. And you can see that the primary bugs for co-infection was bacteria. However, virus co-infection was slightly more frequent in RSV patients, involving 18% of the patients, compared to 4% for influenza patients. The respiratory support at diagnosis in the two groups is shown on the graph on the left side. You can see that 1/3 of the patients were invasively ventilated. NIV was more frequent in RSV patients, used in 27% of patients compared to 19%. And conversely, high flow oxygen through nasal cannula was more frequently used in influenza patients. Accordingly, with the COPD status, PaCO2 was higher in RSV. This is shown in the table on the right. 54 millimeter of mercury in mean compared to 46. PAF ratio was very similar between these two groups, but IRDS was more frequently present in influenza patients, 1 out of 5 compared to 1 out of 6. So regarding the outcome, invasive ventilation was was as frequently necessary between the two groups, roughly 40% of patients. And even if IRDS was more frequent in influenza, you can see that ICU mortality was very similar, 20% of patients. ICU length of stay in survivors was totally similar, and hospital mortality was also very close, 22 to 23%. And even after adjustment on confounders, RSV infection was not associated with better survival, with an odds ratio of 0.8. So to conclude, RSV infection is common in adults, mostly in elderly and comorbid patients. Its detection is common in the ICU, but further works are required to see if it necessarily implies that there is an infection with RSV. In a large multi-center study, we observed that RSV was more frequent in COPD patients, more associated with bronchospasm features than influenza. Conversely, influenza appeared more virulent with more IRDS, higher SOFA score. But despite these differences, resources consumption and outcome were similar in terms of ICU length of stay, mechanical ventilation requirement, and mortality. And in our mind, these results justify the research that are ongoing to find efficient RSV vaccine and also an efficient antiviral treatment. Just want to finish thanking all the captive investigators from France and Belgium that are listed in this slide. Thank you for your attention, and I wish you a nice end of day.